Well, good afternoon. My name is Ian Parney. I'm a neurosurgeon here at Mayo Clinic, and I am joined today by Dr. Alyx Porter, who's a neurologist at Mayo Clinic as well. We are doing this webinar from both Rochester, where I am, and from Arizona, where Dr. Porter is. And our topic today is brain tumors from diagnosis to recovery. So, I'm going to speak first, and we'll hand off to Dr. Porter later. But what I'm going to talk about today is the initial presentation and management for people when they're first diagnosed with brain tumors. My objectives in going over the talks today are really to discuss brain tumor symptoms and management at presentation, to review the role of surgery for brain tumors, and to discuss clinical trials involving brain tumor surgery. Symptoms for brain tumors are really pretty non-specific. The most common symptoms are things like headache, seizures, weakness or numbness, often if it's limited to one side versus both sides, and other things, speech difficulties, nausea. These are not things that are truly specific for brain tumors, but they're things that commonly occur in brain tumor patients. The key that I think is worth remembering, and I tell all of my patients, is that if these are things that are not normal for you, if you have a change in the headache pattern that is not something that you've had before, that might be something that would prompt a further evaluation. Obviously, if you've had seizures when you've never had any seizures before, something like that would clearly prompt an evaluation. The initial diagnosis and management for brain tumor patients is relatively straightforward. Often, the diagnosis requires imaging, an MRI scan, or less commonly, CAT scans or PET scans, although often CT scans are performed first just because they're relatively easy and fast to get. But MRI scans are really the imaging modality of choice that allows us to see the best possible way exactly what's going on from an anatomic point of view within the brain. Once that imaging has been performed, and if it shows something that looks like a brain tumor there would sometimes be medications that would be prescribed. I have in these slides in brackets that frequently there's no medication prescribed, and I think that that's something that's worth remembering. The simple diagnosis of a mass on an MRI scan or a CAT scan doesn't mean that you have to get any medications right away. But in certain cases, there are things that can be appropriate. For example, medication called dexamethasone, which is a very potent type of cortisone steroid, will sometimes be prescribed for cerebral edema or swelling in the brain around a brain tumor. Anti-seizure medication will often be prescribed, though typically only if a seizure has occurred. If a seizure hasn't occurred, that medication usually is not prescribed just prophylactically. Obviously, as a surgeon, a lot of the things that I deal with are brain tumor surgery. And I think it's worth reflecting on what are the indications for surgery, because not everybody who has something on an MRI scan necessarily needs an operation. But there's a few real indications that we need to think about. The first is diagnosis. While we can see on an MRI scan or a CAT scan a mass, and we can form a pretty good educated guess as to what that mass is, we can't say for sure. And the only way to know for sure is to get a piece of the tissue and have a pathologist look at that under the microscope so they can tell us what that is. So surgery obviously plays a role in getting that piece of tissue. We're also interested in surgery for debulking tumors. Sometimes if we can't get all of the tumor out, we still want to get the majority of it out so that we can reduce symptoms and get more benefit from other therapies to follow, be those things like radiation or chemotherapy or so forth. So again, symptom improvement, we want to remove the tumor as much as we possibly can. And then finally, of course, we're interested in cure. Now, not every brain tumor patient can be cured with surgery, and many cannot. But there are some that can be cured with surgery, and I think that's worth remembering as well. So let's just start with that. Let's talk about brain tumors that can be cured with surgery. And these have certain characteristics in common, regardless of what type of tumor they are. They tend to be benign tumors. We're not talking about cancers if we're going to be curing that with surgery. And in keeping with that, they're very well circumscribed. They don't have big edges that, or they don't have edges that we can't detect that sort of meld into the brain. They usually have a very well-established edge that we can get around. Finally, they're accessible. They have to be somewhere that we can get to surgically to take them out relatively easily. There are such things as benign tumors that are malignant by location. So tumors that the pathologist may look at and say, well, it's not a cancer, it's not a malignant tumor, but it could occur, for example, at the base of the skull, where it can be very difficult to get all of those tumors out at surgery. So the things that are surgically curable are benign. They have well-defined borders, and they're accessible to the surgeon to take out. So the kinds of things that could fall into that category are tumors called meningiomas, which are tumors of the meninges covering the surface of the brain, vestibular schwannomas, otherwise known as acoustic neuromas, and pituitary adenomas, benign tumors of the pituitary. There are other tumors as well, but these are some examples of tumors that can be cured by surgery. And here's an example of that. This is a woman in her early 50s who presented with some headaches and had an MRI scan that was performed. And you can see this is an MRI that is with contrast. You can see this white contrast-enhancing mass over the surface of the brain. This is not in the brain, but it's arising from the surface of the brain. You can almost see a little bit of a tail coming out. You can see that particularly on these images up here. And it's pressing into the brain as opposed to invading into it. There is a little bit of this dark stuff here, which is some swelling around the brain, and it looks white on some of these other images through here. This is a very characteristic appearance of a benign tumor called a meningioma. But that is the appearance of this. So we're able to go to the operating room and take this tumor out. And here's a post-operative image taken the next day after removing this tumor. And there's some blood products and things right around the site of the tumor resection. There's still a cavity there, but the brain is intact and really has been untouched by this surgery. The tumor is completely removed. And I can tell you that this particular patient is now 7 years out without no sign of her grade 1 benign meningioma ever recurring. So this is an example of a surgically curable tumor. We still have to watch and see and make sure that nothing comes back, but the chances are that nothing ever will in this particular case. There's other indications, though, for surgery beyond cure for brain tumors. And these are the cases where we're thinking about trying to improve symptoms, or trying to remove as much tumor as possible, even if we can't get it all out, so that we can get more benefit from other treatments like radiation or chemotherapy to follow. The characteristics of tumors that would fall into this category are tumors that are malignant, brain cancers, tumors that are infiltrative into the brain. And again, they have to be accessible. If this is in an area of the brain that we can't safely remove, then that's not something that we're going to propose to do for anybody. The kinds of things that fall into this category are tumors called low-grade gliomas or anaplastic gliomas, which would be grade 3, glioblastomas, tumors that have metastasized from elsewhere in the body. These would all fall into this category where we might consider surgery to remove for improving symptoms and to debulk as much of that tumor as possible going forward. So here's an example of that. This is a young man. He was 21 years old when he presented. Who had really fairly mild symptoms, a modest increase in some headaches that he'd had for a number of years, but led to this imaging, which looks quite different from that imaging we just showed. Here's this tumor with a shaggy margin to it and a cyst with a wall around it that is not pressing in from the outside, but it's involving the brain itself directly. And even though it looks like it has a bit of an edge out here, I can tell you when we operate on tumors like this, there's no edge there at all. This just melds imperceptibly from the mass into the surrounding brain. Nevertheless, we can operate and take a tumor like this out, and this is a post-operative image where we can see that tumor has been completely removed. Again, some blood products around it, a little bit of swelling in the brain around here, but for all that we can see on the MRI scan, the tumor has been completely removed. However, in this case, this is a much more aggressive tumor, a grade 4 tumor of the brain that even with surgery like this, although it helped his headaches and although he did better in terms of his time to recurrence and things after this than he would have if we hadn't been able to take this out. This is the type of tumor that has the tendency to come back down the road. Nevertheless, taking it out like this, I think, made a significant impact on his survival. And he tolerated the surgery very well without any new neurological deficits at all. He actually went home the second day after his surgery. So I think it's worth asking this question: is there value for cytoreduction in gliomas? And this is a big word, cytoreduction, that I tried to get rid of my slides and I couldn't find it there to actually get rid of it. But what I'm talking about here is just, is there really proven benefit for taking out a tumor if we can't cure, rather than just, say, doing a needle biopsy and going on to get radiation and chemotherapy? And I think the answer to that is yes. It's still a little bit controversial. But for example, here's some data from a review that we put together a few years ago, looking at a whole number of different studies published over about a 20-year period, looking for the most aggressive tumors in the brain for the average survival after surgery, depending on whether this was a complete removal, a subtotal removal, a partial removal, which would be less than 50%, or just a biopsy alone. And essentially, across all of these different studies, the more tumor was able to be removed, the better people did in their overall survival. Now, there's a problem with a lot of these studies in that they tended to be retrospective, and another way to interpret this could be, well, tumors that we can take more out of tend to grow more slowly. And it's not quite the same as saying that it's proof that taking more out, people do better. We do have some data that's a bit more prospective, and this is from a paper that I was involved in a number of years ago now, looking at prospective data in patients at 55 centers across North America for both grade 3 and grade 4 tumors. The grade 4 are these glioblastomas, or GBMs. Grade 3 are what's listed here as non-GBMs. And essentially, for both grades of tumor, if we were able to take some of that tumor out compared to just doing a biopsy, patients did much better, whether it was grade 3 tumors or whether it's grade 4 tumors. So again, prospectively, there's a lot of data that would suggest that this is associated with better outcomes for patients. That's still not the same as a randomized study where patients would be randomly assigned to either have more taken out or less taken out. Obviously, there's some problems with doing a study like that, in that most people would say, well, if you can take it out, take it out. There is some randomized data that certainly supports this for grade 4 tumors, and this is from a paper from a German group published in 2006, where they had a technique using a type of fluorescence called 5-aminolevolunic acid, 5-ALA. This is an agent that can be given before surgery to make the tumor fluoresce and help the surgeon see where that tumor is. And they looked at a number of different centers. I think it was 9 centers in Germany with a number of different patients with grade 4 tumors, and they compared whether they were able to get more tumor out with the fluorescence of the 5-ALA compared to white light. They definitely were able to get more tumor out as a group with the 5-ALA, the fluorescent guided surgery. But moreover, this was associated with an increase in progression-free survival, and there's other data that would say that it's increased with overall survival as well. So this is some randomized data where patients were randomly assigned to these two groups that showed that, at least with this technique, there's an ability that they were able to get more tumor out in the surgeons that were doing it. This particular technique, the fluorescence, has been adopted in some places in the United States. It's been a little bit hard to get it adopted by the FDA for a number of different reasons. One issue with it is that if you're already a pretty aggressive surgeon, you already take out most of that tumor. And I know here at Mayo Clinic, we're pretty aggressive about taking all that tumor out already. And we use some other techniques like the intra-operative MRI, which I'll talk about here in a little bit. Not every tumor needs to be taken out. Not every tumor should be taken out. Sometimes tumors are in deep areas of the brain where trying to take that out is going to be dangerous, and it's going to cause problems for patients. And if you're hurt by the surgery, to take the tumor out, it's pretty clear that that has a huge impact on any benefit that you might have had from the surgery in terms of survival. So sometimes we'll think about just doing a biopsy, and there's a number of different ways we can do that. You'll hear people talk about stereotactic biopsies, Sometimes that's done with a frame-based system like this, and here's an example of one of my patients where we did a frame that was attached to the head and then did a biopsy to this deep-seated tumor in this location. More commonly now, though, we use frameless stereotactic techniques, and this is a scenario where prior to surgery, a patient would have a number of stickers placed on their scalp. They would have an MRI scan, and then that MRI scan gets sent to a computer in the operating room. It's hooked up to 2 infrared cameras that can see the stickers and see a wand that we point at the scalp. And that'll show us in 3 dimensions where everything is. We can use that to help guide an instrument just a little bit bigger than a needle down into to take a biopsy, including, in this case, of a very small, deep lesion here that would have been really very dangerous to try and take out, but we were able to get the biopsy without any problems at all in this patient. In terms of how we take tumors out, of course, there's lots of different things that we do in general, and this is just some cartoon images of this showing that we tend to try and avoid the blood vessels around the tumors. We'll sometimes get into the tumor and debulk it centrally and then take the tumor out around from there. And this is how we can get into areas that are otherwise difficult to access. There's a number of things that we can do to make the surgery even safer. A very common technique in neurosurgery is the operating microscope. And a number of years ago when I was still in training at San Francisco, I asked my boss at that time, Dr. Berger, who was the professor and chairman at UCSF, why he used the microscope to operate on all his brain tumors so much. And he said, well, I can see better. And well, that's pretty hard to argue with, so I use the operating microscope for most of my cases as well because I can see better. We also use intra-operative image guidance, and you'll hear people throw this term around. And this is really the same technology we just talked about for the frameless stereotactic biopsy, putting the stickers on the scalp, getting that MRI scan, and then we can get these 3-dimensional images of the brain that we can use to help guide the surgery. Often when I'm seeing patients in clinic, they'll say to me, well, goodness, doctor, isn't it obvious? Just take out the white bit. We see those MRI scans with a big white lump in the middle of it. And I can tell you it's nowhere near as obvious at surgery. These things will often just meld imperceptibly to the surrounding brain. And with experience, you can tell the difference, but that MRI guidance is really critical and very, very helpful. When we take out a big lump in the brain, a big tumor that's there, the brain is actually going to shift a little bit. And the more that we take out, the less and less accurate our image guidance is based on the MRI scans before the surgery. And so at the end, when we really want to know, did we get everything out? Is there any more that we need to take out here? We're kind of got our least accurate view of this. So one of the things that's nice here at Mayo Clinic is we have intra-operative MRI, where we can get an MRI scan during the surgery to re-register our guidance system to see how we're doing and use that to help us take out the tumor. MRIs show us a lot about the anatomy. They don't necessarily show us the function. We can get some other information about function, where motor areas are, where speech areas are, where critical white matter tracts are with certain types of functional MRI scans, and this is some examples of that. But more often than that, and this is one of my favorite Far Side cartoons, we do something called electrophysiological mapping during the surgery, where we put a little electrical stimulator down on the surface of the brain and we see if the patient will twitch on the opposite side, or we'll see if we're able to interrupt their speech, which of course has some implications. If we're talking about interrupting speech, patients have to be awake. The brain has no sensation, so that's how we can talk about doing an awake brain surgery. But of course, everything else has lots of sensation in the scalp and everything overlying that. So patients are quite sedated initially. There's a lot of local anesthetic that's given. But then when everything is open, we're able to stop, have the brain exposed, and go ahead with his motor and speech mapping, just like it says in this Far Side cartoon. Well, that was a good one. Try it, Hobbs. Just poke his brain right where my finger is. See his leg twitching. I already said that surgery can cure some tumors, but it can't cure every tumor. And there are other critical treatments that you're going to be hearing about from Dr. Porter in just a minute in terms of radiation and chemotherapy and some other novel therapies as well. I'm just going to talk very briefly for my last couple of slides here about brain tumor immunotherapy, which is something that is near and dear to my heart, and my other hat, other than being a brain tumor surgeon, is to be a brain tumor researcher. and look at new ways to stimulate the immune system to try and eradicate tumors. A lot of this involves surgery. So, for example, we have trials open right now for something called a dendritic cell vaccine. Dendritic cells are just normal white blood cells. They're very potent ways of stimulating the immune system. And what we do is we'll operate on a patient, get rid of the bulk of the tumor, and then we'll get a sample of their own blood to get some of their white blood cells so that we can culture and expand their dendritic cells. We actually have a number of clinical grade human brain tumor cell lines that we've grown in culture that we can use as a source of tumor proteins. And we'll use those to pulse patients' own dendritic cells and use this as a vaccine that we give back just as an injection underneath the skin to stimulate the immune system to attack the tumor. We have this trial that's open right now called MC1272. Very, very exciting, dynamic name, MC1272. But it's a trial of dendritic cell vaccines combined with standard therapy for patients with newly diagnosed glioblastomas. There are other types of vaccines. In general, we think of vaccines as things to get rid of the measles, mumps, and rubella, but really it's anything to stimulate an immune response, and it's a big thing that people are looking at for a lot of different types of cancers. There's different approaches here. One general approach would be just to get purified tumor antigens or tumor proteins from a tumor cell and use that to try and stimulate an immune response. We talked about using dendritic cells just now, white blood cells from patients to stimulate immune responses. Another option that we're involved with here is using heat shock protein peptide complexes, or HSP complexes. Heat shock proteins are little molecules within the cells that act like chaperones, and they take other proteins around and bring them to different parts of the cell. So there's certain heat shock proteins that are really good at presenting things to the immune system to stimulate the immune system to attack whatever they're carrying. So we participate, and I'm the National Study Co-Chair for a trial that's run through the Alliance for Therapeutic Trials in Clinical Oncology at about 25 different sites across the country right now for patients with recurrent glioblastomas, looking at heat shock protein peptide vaccine compared to standard treatment with a medication called Avastin or bevacizumab. So I think with that, I'm going to stop, and we're going to switch to Dr. Porter in Arizona, and she's going to talk to you about some other things regarding the treatment of high-grade glioma, and then we'll have some time for some questions at the end.
Thank you so much, Dr. Parney. So when we're talking about high-grade glioma, we're really talking about a few different tumor types. One is a grade 4 astrocytoma, also known as glioblastoma multiforme, and then grade 3 tumors as well. So you can have a grade 3 astrocytoma, a grade 3 oligodendroglioma, or a grade 3 mixed tumor, oligoastrocytoma. These tumors can also be known as anaplastic oligo or anaplastic astro, anaplastic oligoastrocytoma. And so when we talk about treating these tumors, we tend to treat them the same way. And so historically, there is a combination treatment known as PCV, and this is a combination of procarbazine, which is IV, CCNU, which is oral, and vincristine, which is also IV. And this stopped being used mainly about 10 years ago, but the data now has matured for some of those grade 3 oligodendrogliomas that were treated with PCV, and those patients are actually showing prolonged survival. There are clinical trials going on now looking at whether PCV is just as good as what we're using now, which is temozolomide, which we'll talk about a little bit later. And so we'll find out soon whether or not it's better to use this older regimen, which tends to be a bit more toxic than the newer regimen that we're using. So nitrosoureas are a category of medications which include BCNU and CCNU. And the BCNU wafer is used most commonly in other institutions, not necessarily at Mayo, but mainly for high-grade glioma. And what happens is that the surgeon will implant these wafers within the resection cavity. The difficulty and why this treatment isn't being used everywhere is you can get a local reaction in the surrounding tissues from this chemotherapy, and it makes it very difficult to treat. It's hard to know whether or not what you're seeing is just inflammation on the MRI or if what you're actually seeing is progressive tumor. So as I mentioned, the treatment for glioblastoma and high-grade glioma really changed about 10 years ago when this landmark article came out, first authored by Dr. Roger Stupp. This is also known as the Stupp protocol. And this treatment consists of a combination approach of both radiation and an oral chemotherapy called temozolomide. The radiation goes on for 6 weeks, Monday through Friday, and the temozolomide is every day during those 6 weeks, so 42 days in a row, followed by a 1-month break, and then temozolomide is given for about 6 months, 5 days a month. And this is, as I mentioned, mainly known as the STUP protocol. It's a combined treatment, and this is known as the gold standard, the upfront therapy for most high-grade glioma. If a patient's tumor has grown back in spite of this initial upfront therapy, the FDA has approved the use of bevacizumab, which is a monoclonal antibody. It's an infusion that's given every 2 weeks, and that can be an effective therapy for quite some time. There have been studies looking at whether or not it's better to use bevacizumab up front in combination with the chemoradiation, and there's not been any difference in overall survival when it's used initially, although those patients have been shown to have increased side effects. We're starting to get closer in our understanding of the different components of glioblastoma and high-grade glioma and what molecular alterations take place that can impact how a patient responds to therapy and what their overall prognosis may be. And so I mentioned some of them here. Many of these can be obtained through comprehensive gene profiling. There are some, like this TERT mutation, that is still being used mainly on a research basis, but work is being done to be able to bring that to mainstream. So I'll just point out a couple of things from this slide. So this is what's considered a triple positive tumor. That's someone who has this IDH1 mutation, the 1p19q co-deletion, and a TERT mutation. Those individuals are felt to have the best prognosis. In fact, median survival has not yet been reached at around 10 years, which is impressive. These patients tend to present more with grade 2 and grade 3 tumors as opposed to grade 4. The other group I'd like to point out is on the opposite end of the spectrum. Those are the patients with this TERT mutation. Those patients tend to be older at their age of presentation and tend to primarily present as grade 4 glioblastoma. On this slide, this is just a graphic to point out again that TERT is most common in the grade 4 population, and the others, the triple positive, the IDH1 mutation, is most commonly seen in grade 2 and 3 and can be associated with an improved prognosis as opposed to those with the TERT mutation only. Again, the TERT mutation is associated typically with an older age of onset, where the others, the IDH1, for example, or 1p19q, tends to be associated with a younger age of onset, also again with grade 2 and grade 3 tumors. In terms of the overall survival, when we talk about tumors such as EGFR, tumor molecular alterations like EGFR, we know that patients who don't have this molecular alteration tend to do better as opposed to those who don't. Also, same is true for those with the EGFR V3 alteration. Those patients have an improved survival as opposed to those who don't. P10 and P53 are other molecular alterations that can be found. P10 is a tumor suppressor gene. When that is mutated, turned off, those tumors tend to grow more rampantly, allowing those patients to have a poorer prognosis, as opposed to those with a P53 mutation who have an improved prognosis there. The 1p19q co-deletion is most commonly found in anaplastic oligodendrogliomas, or grade 3 oligodendroglial tumors. Those patients with that deletion tend to have an improved survival and an improved response to chemotherapy. The MGMT it stands for methylguanine methyltransferase, and this is a DNA repair enzyme. So once you give a patient temozolomide or an alkylating chemotherapy, the idea is that you're breaking up that DNA, and if you have the MGMT, the sort of fix-it enzyme, turned on, no matter how much chemotherapy you give that patient, those DNA cells are going to repair themselves and the cancer will continue to grow. So we found if this MGMT is silenced, meaning it's methylated, If a patient has that genetic alteration, their cancer DNA does not repair itself, and they respond better to chemotherapy. And so here we have that survival curve, and you can see that those patients with methylated MGMT have an improved prognosis compared to those who don't. So this is the schema for how the STUP protocol, the combo of radiation plus temozolomide versus just radiation alone, this is the schema for how that trial was constructed. And the interesting results were that when you look at the overall survival, although this number may not initially appear to be impressive, a 2-month difference between whether the patients received temozolomide or didn't, where we started to get excited was the 2-year survival. And so here we were seeing that 1 in 4, at least 1 in 4 patients were living 2 years, as opposed to, with just radiation alone, about 1 in 10 living 2 years. When you break it down further by whether or not that fix-it enzyme was methylated or unmethylated, the patients who had methylated MGMT have a 2-year survival that almost reaches 50%, which is very different than someone who is unmethylated. And so that's why that particular genetic alteration has such important prognostic value. Again, you can see here on this survival curve, the patients who are methylated, who received radiation plus temozolomide chemotherapy, do much better than those patients who are unmethylated. We have lots of different targets that we can reach, and if you imagine this being a cancer cell, we've got the outside of the cell and then the inside of the cell, and there are several targets along the way that different drugs are being developed to try to impact. And so this is the outside of the cell now, and we've already talked a little bit about bevacizumab. We'll talk about it a bit more, but this is an antibody that helps block the tumor's ability to grow and develop the blood cells that it needs to continue to grow. So you can imagine, with all of these different stop points and the various drugs that are being developed, there's not just one answer for how we're going to learn to contain high-grade glioma. In fact, I think it's going to take a combination approach, not only different target points, but also immunotherapy, as Dr. Parney mentioned. And so that's what's taking so much time in terms of what's happening with brain cancer research. So this is the trial that led to the FDA approval of bevacizumab for recurrent glioblastoma, or recurrent high-grade glioma. Here's an example of a patient whose tumor on the left panel was pre-treatment before the bevacizumab. And then on the right side, this is a patient's tumor after the bevacizumab. And so you can see that some patients have a very dramatic response in how their tumor appears pre and post treatment. The difficulty with bevacizumab is, number one, not all patients respond this beautifully. Number two, the response may not last long. And so this next trial that was done looked at adding CCNU to the bevacizumab. And so what was done is to figure out whether or not adding the lomustine, or CCNU, helps make the length of time that you get a durable response from the bevacizumab better. And we found that indeed it did. You'll see in the top 2 curves, those are patients who were exposed to bevacizumab plus lomustine. The top blue curve is that with a dose of 110 milligrams per meter squared. The purple curve was a dose of 90 milligrams per meter squared. It appears as though the higher dose had an improved outcome, but note that there were only 10 patients in this group, and so the side effect profile was a bit more with the 110 milligrams per meter squared, so it's favored to use the 90 milligram per meter squared dose. Another option for recurrent disease, recurrent high-grade glioma, is a medical device that was FDA approved a couple of years ago for patients who have had their tumor grow in spite of being on the chemoradiation with Temodar, had their tumor grow in spite of a trial of bevacizumab. And these are electrodes that are placed on the scalp, and there are wires that come down, plug into the battery pack. And when turned on, you have these what are called novel TT fields. The frequency that these fields emerge at disrupt the cancer DNA from replicating and does not affect normal brain cells. The difficulty or the main side effect associated with this treatment are the abrasions that can occur on the scalp from the presence of the electrodes. The way the study was developed that led to the FDA approval was they took patients with recurrent glioblastoma who, again, their tumor had grown in spite of chemoradiation as well as bevacizumab. They randomized patients to either have the medical device or for a physician to then choose a next chemotherapeutic option. And the reason why this treatment was exciting was patients seemed to have just as good of a survival curve, maybe better than the chemotherapeutic option, and their quality of life, so not only their cognition, but generally how they felt, their global health and their emotional functioning was much better than that third-line chemotherapy. So in the instance where a patient might have evidence of recurrent glioblastoma, if the tumor has grown back without being on temozolomide, it's certainly reasonable to retry the Temodar. If the tumor has grown back on Temodar, it's reasonable to try bevacizumab or CCNU first, or the combination of both. It's also reasonable to consider the Novo TTF medical device. However, whenever anybody has a newly diagnosed or recurrent high-grade glioma, clinical trials should also be considered. Currently, we have 17 clinical trials at Mayo Clinic. Various trials are open at different sites, but I'd like to point out a couple. We spent some time talking about the MGMT, that's the fix-it enzyme, whether that's methylated. We have a trial specifically for that. We have a trial specifically for patients whose high-grade glioma has recurred in spite of having had exposure to bevacizumab. Dr. Parney mentioned some of his vaccine trials here, and then I'd like to point out my own trial here at the bottom, really focusing on quality of life and improving cancer-related fatigue for patients with high-grade glioma with a secondary endpoint of improving cognition. And lastly, another trial that is designed for those with MGMT promoter methylation. So we know in conclusion that there's a benefit to receiving chemotherapy when added to radiation therapy up front for those patients with a newly diagnosed glioblastoma or high-grade glioma in general. We're starting to understand more about the molecular physiology of these tumors, and there are markers that we've identified that can predict who may have a better outcome and which patients may respond better to our chemotherapies. The answer, though, doesn't lie with just one medicine or just one modality. We believe that targeted therapies in combination, as well as angiogenesis inhibitors, immunotherapy, all of these are highly promising for both newly diagnosed and recurrent disease.
Okay, well, thank you very much for that, Dr. Porter. We have a number of questions now that are coming up through the web, and please keep them coming. We're happy to answer these questions as they come up. We'll start with one question here that's probably best for Dr. Porter, so I'll ask you if you want to weigh into this, and I can weigh in as best I can as well. But first question we have is, what is the best treatment for a PNET tumor? So, Dr. Porter, would you care to comment on that?
Sure. So the PNET, it really does depend, number one, on where it occurs. And so typically we start with surgical resection. If we're talking specifically about medulloblastoma, there's a combination of radiation as well as chemotherapy that can be most effective. So oftentimes it depends on, number one, where the tumor is. Can it be resected? Number two, are there other sites of disease? Has there been evidence of what we call drop metastases? Are there lesions within the spinal cord or down into the cauda equina? After that, radiate based on whether or not there's drop metastases or whether or not the tumor can be excised. Radiation and chemotherapy may be options.
Next question we have is question from someone who writes that they have a clivus bone tumor. A clivus is a part of the bone at the base of the skull. After biopsy, it came back as something fibroosseous. They say that they have symptoms and they're monitoring. The tumor is up to about 5 centimeters, and the question is this standard for this type of tumor? Of course, a little bit difficult to comment without knowing all the details from your imaging and the biopsy and so forth. But there can be benign non-neoplastic, which is to say non-tumorous things that can occur at the base of the skull that are fibroosseous like that. And depending on exactly what's involved on the imaging, it may be reasonable to monitor at this point. However, there may be other possibilities, and it would certainly be worth getting opinions if you wish to get any further information about that. Next question we have is about immunotherapy. Is it an option for everyone? And maybe we can just scroll down a little bit so I can see that question a bit more. When would be an ideal time to be considered? So immunotherapy is something that I can speak to. It's very much an experimental treatment at the moment, which means that it's only in clinical trials. This isn't something that's standard treatment that would be available to everybody. And for every clinical trial, there are specific indications and time points and so forth. The trials that we have open right now at Mayo Clinic, there's a trial that's open for patients with newly diagnosed grade 4 glioblastomas, and there's a trial that's open for recurrent grade 4 glioblastomas. There are some specific requirements for each of those studies, but if something has been diagnosed for the first time and it's before having had any chemotherapy after the initial radiation chemotherapy, that would be an option for our clinical trial right now. In addition, if there's been a recurrence diagnosed after a prior grade 4 tumor, either the first or second recurrence, it would potentially be something that would be for our second clinical trial for recurrent glioblastomas, although again there's some specific criteria for those studies. Okay, so there's a question here that maybe I'll ask Dr. Porter to weigh in on. It says, my husband has had seeding of a tumor in the ventricle for the past 26 years. He recently had a surgical biopsy, and the pathology, the report showed a grade 2 astrocytoma, but the neurologist thinks that the pathology report was not correct, and he thinks it's an ependymoma. My husband is 68 years old now and has never had radiation or chemotherapy, only surgery to stop seizures in the left temporal lobe. And then the question is, what is the prognosis for an ependymoma about 3 centimeters? So Dr. Porter, would you care to comment on that?
Sure. So I think that this situation might be an excellent one to get a second opinion, not only clinically for diagnostic purposes, but also to have the pathology reviewed. It's very important to make that distinction between an astrocytoma or an ependymoma. If the seeding has been there for 26 years and it's not progressed, typically that's a really good sign that this is a very slow-growing tumor without highly malignant features. Based on the pathology, though, the specific makeup of the tumor, the prognosis for ependymoma changes. You can have a benign ependymoma that is essentially curable with surgery, all the way up to a grade 3 ependymoma, which is anaplastic, or it can be highly malignant, requiring radiation and chemotherapy. So I think your husband's situation is unique, certainly needs a bit more investigation.
We have two, I think, fairly quick questions here that I'll answer the first, and then Dr. Porter will have you answer the next one here. The first question is, where can I find a list of clinical trials at Mayo after just having had brain surgery? So if you go to our website, mayoclinic.org, and type in brain tumors, you'll get to the brain tumor website homepage, and on that there's a link to clinical trials, and that should give you some information there. The other thing that you can always consider is coming for a consultation at Mayo Clinic at any of our sites where there's neuro-oncology, so Rochester, Arizona, or Florida, and meeting with a neuro-oncologist, and they can talk to you about clinical trials there. The next question for Dr. Porter here is, please talk about recurrence of a brainstem glioma after doing the Stupp protocol.
So the same rules apply in terms of disease recurrence. The only thing that I didn't mention earlier that doesn't necessarily apply to brainstem glioma is it really does depend on where the disease recurrence occurs. For some patients, it's reasonable to have a re-resection or surgical management of their recurrence. Unfortunately, with brainstem glioma, surgery isn't an option for disease recurrence, and you're left with medical management. That Novo TTF medical device would not be an option because really that device is designed for supratentorial disease in order for the alternating TT fields to be effective. There's no way they'd be able to have an alternating field to hit the brainstem area just based on anatomic location. So recommendations would be either a retrial of temozolomide, potentially bevacizumab, potentially adding CCNU or trying CCNU alone. And then, of course, looking into whether or not there are clinical trials. To my knowledge, at the present time, there are no clinical trials available for recurrent brainstem glioma across the country.
We have a question here addressed to me. It says that you have been doing some pioneering work in oncolytic virotherapy with the measles virus. Would your recommendation for oncolytic virotherapy be based on the genetic makeup of the tumor? And what virus would be most effective in what circumstances, measles virus or Newcastle disease virus? So just to take a step back from that, oncolytic virotherapy is the science of trying to use viruses to directly treat tumors. The idea is that there are certain viruses that either by a natural fluke, so to speak, or through genetic engineering, will infect and kill tumor cells but leave normal cells unharmed. And this is a really exciting area within cancer research in general, and something that I've had the privilege of being involved with in a number of different clinical trials for malignant brain tumors. Right now, we have a trial that's open for patients with recurrent grade 3 or grade 4 gliomas for treatment with a measles virus for that tumor. The enrollment in that study is not actually based on the genetic changes within the tumor. It's really based on the type of tumor, whether it's a grade 3 or grade 4 tumor. There's some other anatomical criteria as well, because there are some surgical things that have to be performed as part of that surgery. But it's an early study, a phase 1 study, but it has been promising for us so far. And in the case of a recurrent grade 3 or grade 4 tumor, it may be an option. In terms of what type of virus is going to be the best, I think if I knew that right now, I probably wouldn't be here. I would be out buying stock in whatever company had that virus there. I think there's a number of different options that are available. Obviously, we have done some work with the measles virus, and that's been very promising, both in malignant gliomas and in a number of other cancers, and we're excited about that. There's work being done near future for patients, pediatric patients with malignant brain tumors. There's a number of colleagues here in our Department of Molecular Medicine and our Department of Immunology that are working on other viral vectors, things like the vesicular stomatitis virus, or VSV. There's work that I and a number of other colleagues are working on with something called TMEV, Tyler's murine encephalomyelitis virus, and a variation on that that has been in clinical trial in other cancers called Seneca Valley virus. And then there's a whole number of other viruses that people are using in different trials in different types of tumors and other locations as well. I don't think we know at this point which is going to be the best virus to use. But I think one thing that's becoming very clear is that in addition to the virus being effective by itself to just infect and kill tumor cells, it's becoming more and more clear that part of what this is doing is stimulating an immune response against the tumor. And so now a lot of us who are interested in viral therapies are actually combining this with immunotherapies to try and directly stimulate immune responses against the tumor at the same time. We have a question here that I will maybe ask Dr. Porter to weigh in on, is what would be the best treatment approach for a tumor that is unmethylated with no mutation in IDH1 or 2 genes, how would Mayo personalize the treatment for such a tumor?
So that's a tough situation, and we've not yet progressed enough in our treatment of high-grade glioma to be able to offer other alternatives. So in that particular instance, still the same treatment would apply for most patients. If a patient is elderly and they're over age 80, it may be considerable to just do radiation alone if a patient is unmethylated and does not have an IDH1 mutation. You really have to weigh the risks and the benefits and the side effect profile associated with the chemotherapy to make a decision as to whether or not it's worthwhile. We've just not yet reached the point where we have other alternatives to use up front that have been shown to be effective in that particular population. So generally speaking, in a younger person with a good performance status, we're going to continue to be as aggressive as we can in spite of what the molecular profile looks like.
Here it says, I have a small meningioma wrapped around the superior sagittal sinus. It continues to grow slowly. I'm being told it's too risky for surgery because of the area. I was also told that radiation is not recommended. Is this typically how this is approached? Again, it's hard to know without having seen you and having seen your MRI scans to know exactly whether we would recommend surgery or not, or if there would be any other alternatives. It's a common location to have meningiomas near the sagittal sinus, and that can limit the ability to resect that area completely because the sagittal sinus is something that can't be safely tied off and divided. That could lead to stroke. However, sometimes the sagittal sinus will be slowly blocked off over time by a tumor itself, and in that case, it sometimes can be possible to resect the tumor completely even when it's near the sagittal sinus. So probably need to see the imaging and know a little bit more. The other thing we'd have to know is whether it would be an option to have any type of surgery, something that we commonly do, or any type of radiation, something that we commonly do for residual meningiomas up by the sagittal sinus where we can't resect them, is to treat with a very focused type of radiation called radiosurgery, and often that would be with a tool called a gamma knife, although there's other linear accelerator-based systems as well. So I think that it'd be something that I would encourage you to get opinions on. Because I think that there may be some options there. Difficult to say without having seen the scans themselves. We have, I think, time for one or two more questions. I'll ask Dr. Porter if she could maybe comment on this. The question is, I read somewhere that being positive for EGFR is a good prognostic indicator for glioblastoma in the elderly. Is that correct?
As long as the EGFR is mutated, yes, that is correct. That is associated with an improved prognosis.
Our last question, or next to last question here will be, in the biomarker report, I was positive for methylation. However, it was listed that I was 37% methylated. Does the percentage have any bearing on prognosis? That's actually an excellent question, and it's one that I keep asking our pathologists here as well, and I'm not sure that I've got the best answer to that yet. I think the short answer is no. I don't think that it has any bearing on prognosis. I think that that's partly because it's pretty controversial exactly what that percentage means, and it may mean different things in one lab compared to a different lab. So I think as best anybody's been able to tell, that percentage doesn't make a difference for prognosis. But it's actually something that I think is still an active area of investigation. So maybe we have time for one more question here. So the question is, I am post breast and thyroid cancer surgeries, oophorectomy, chemotherapy, biologic radiation treatments, and currently receiving oral therapies. I now have a brain cyst on the MRI next to the pineal gland. Had a number of symptoms for at least a year and a half with headaches and some nausea and other symptoms. Been given medications for headaches and steroids and other injections. Are there any other options to consider? Again, difficult to say without having seen the MRI scan and without having seen you. There are truly benign, non-cancerous cysts that can occur in the pineal gland that are not necessarily causing any symptoms at all. And I think that'd be one of the first questions is this cyst causing the symptoms, or is there something else that's causing the symptoms? So I think seeing the MRI scan and coming to the diagnosis would be critical. Sometimes if there is a mass in the pineal gland and it's causing symptoms, that can be caused through hydrocephalus, or the spinal fluid backing up within the ventricles. And there may be some options that could be considered surgically for that, but again, difficult to say without having seen the MRI scan and having seen you yourself. So I think we will wrap up there. I thank you all for joining us today. Thank Dr. Porter for our excellent talk and answers to the questions. I apologize if we weren't able to get to all of your questions today. We will try to answer any additional questions in the following week or so, and we'll have that posted on the webinar website. So thank you again for joining us today, and we'll sign off now from Mayo Clinic.